non-clinicians, these are kind of our last-ditch antibiotics that you use in desperately ill patients when you get points for being not right and not for style. You know, you can put this thing and it just kills them all. And now the problem is it doesn't kill all of them anymore. So that's sort of the challenge. And if you look at these specific pathogens, significant rates, 10 up to 50% of these are resistant to carbapenems, our sort of last go-to drug. And they're spreading. So this is this is data from the CDC, and the point of this slide is how it's expanding. So these are, obviously, this is the map of the United States, and this is superimposed with CRE, the carbapenem-resistant Enterobacteriaceae. The epicenter is New Jersey and so Long Island and all that. But these yellow states are states in which a CRE has been described. So this was in 2006, 2007, maybe a few more, 2011, 2012, and the present. So what's the point? The point is there's a whole lot of yellow, and there's more states turning yellow every year. So now there are a couple of good ones that are like, I don't know what Idaho's doing. But all three people there are doing just fine, and they haven't had a CRE infection yet. So anyway, the point is it's expanding, okay? All right, and it matters mortality-wise. If you have these infections, and it's a resistant infection, you're more likely to die than if you had the same infection with one that had that the bug had a lot of S's beside it instead. You know, so that's the message here: is it has that the resistance is, you know, clinically actionable. It has an impact on our patients. And the Acinetobacter, same thing. More resistance, worse outcome. The Acinetobacter, as for the non-clinicians in the room, this was that really resistant bacteria that was isolated from the troops returning from Iraq. You may or may not have heard about that, those strains, you know, 6-8 years ago. So this is an example of that. And these are highly resistant. And I think importantly, there's resistance to the oral antibiotics. This is arguably as important because it changes the way you manage simple infections that were previously dealt with on an outpatient basis that you didn't think about. And it's to a problem. The problem is to the extent now that the IDSA guidelines, which are sort of our society recommendation of how to manage things, they no longer recommend Cipro for bladder infections because the resistance is so unreliable. You know, in some populations, it's 20 or 30% of the community. And instead are suggesting things like nitrofurantoin or fosfomycin. Well, let me just a show of hands for the clinicians. Who here has ever prescribed fosfomycin? Okay, 1, 2, the ID guys. You guys don't count. Non-ID guys ever prescribed. See, that's my point. I didn't even know how to spell it originally, and so here it's an F and not a P. But anyway, the point is these are really unusual drugs. And so now what do we do when the infections are actually serious? You know? And so this let me just put in perspective with some numbers here. So Danny Benjamin's here. He's a quantitative guy. So Danny, these are numbers just for you, sir, these next few slides, okay? Numbers. So here we go. So just to put, and the point of these slides is we are totally outnumbered, guys. Totally, completely outnumbered. So here you go. You got total number of organisms, of microbes on Earth, somewhere about 10 to the 31st versus about 6 to the 9th human. So we're outnumbered by a factor of 10 to the 22nd. Mass in geometric tons. So we can just take them because we're bigger. No, because there's a problem. It's on the order of 10 to the 8th power, okay? Generation time for a bacteria divide every 30 minutes. For a human, a life cycle, 30 years. And time on Earth, they've been here, well, I don't know what that's a lot of zeros, though. It's billions. So they've been here for on the order of 10 to the 4th times longer than we have, okay? So they're more, and they've been here longer. And what else, the other thing they do that really helps them in their cause of staying alive is they swap DNA around. And they do it a variety of mechanisms. One of the easiest is a thing called plasmids, and they're essentially little cassettes of DNA, and they basically trade them like, you know, when you're kids, you would trade baseball cards. So, and they would trade, and these plasmids contain virulence determinants, They contain resistance mechanisms, and they can shift them readily between strains, often even within the same patient. And they can do this not just within species, but across phyla. So remember the organizational tree. They're able to transmit DNA or exchange DNA with organisms that cross the thing of phyla, where we as humans cross it within species. And now, just to put that in perspective, what that means. For humans to have an equivalent adaptability, we would have to be able to share DNA with our family, not just species, but family. So chimpanzees, okay, well that's maybe. Orangutans, I'm sure there's a joke there somewhere, I can't think of it, but or a primate, so that's fair enough. Grizzly bears, so in our class, mammals, tigers, walruses, killer whales, even down to sea squirts. And you think about, now some of them, has this in fact occur? I don't know, I'll leave that to you, but the point is that the numbers are stacked against us from every level, from the level of adaptability for genetic transfer, from the perspective of numbers, etc. And so then you add atop that adaptability selection. Okay, so here's selection stuff. Here's a little dirty secret that if somebody wants to solve, this is a big one. 80% of antibiotics in the United States never see a human being. Never go to a human being. They go to creatures with 4 legs and not 2. They go to food animals. And they're primarily used, these 80% of antibiotics prescribed in the United States each year, whatever, 13.2 million kilograms, they're used as growth promoting agents. So here's the idea. It's been shown, it works. You give them a small dose, subtherapeutic dose of antibiotics, and guess what? If you give a pig a subtherapeutic dose of antibiotic, it's going to get bigger and fatter and presumably be more valuable than a pig that you didn't give that stuff to. And so as a result, the food industry loves this stuff because it's more valuable, right? Well, there's that little detail about resistance, but what's that line from the Wizard of Oz? Pay no attention to the man behind the curtain, right? So 3.3 million kilos are sold to humans, and so this is a staggering amount of environmental contamination and selection. So then you ask the question, well, maybe it's a recent thing. This is probably one of the more fascinating papers that I've encountered in recent era. So they went down to this cave in New Mexico. And basically, I don't know if you guys have ever gone caving. My daughter talked me into it. I can tell you, it doesn't surprise me that no one has been in this cave for 4 million years because you're in a freaking cave. It's tiny, it's dark. No humans were in this thing for 4 million years. They went down there, they essentially collected samples, and then they brought it up and they asked the question, what are those things, the bacteria that have been down in this sort of human devoid area for 4 million years, highly resistant to all sorts of antibiotics. So what's the point? The point is that these antibiotics these bacteria have been developing antibiotics and antibacterial resistance as a matter of survival for millions of years. And in fact, I guess that's my slide. So microbes have been creating and defeating antibiotics for 20 million times longer than humans have even known that they existed. Okay, so that's, I guess the summary then, the Nobel laureate Josh Lederberg pointed out that the future of humanity and microbes will likely evolve as episodes of our wits versus their genes. And I can tell you who I would bet on. So then, let's see, rats, that slide didn't come through, but here we go. The point then is, coupled to that, so there are a number, so why is the market failing? Getting back to that. So we've heard of some about the science. The low-hanging fruit's been picked, but there are also economic and regulatory issues. This is supposed to be a Venn diagram, and I guess I didn't make the slide well, but the bottom line is, it's this convergence of these 3 points that has led to us, these 3 issues of science, economics, and regulatory issues. that have led us to our current dilemma. And in fact, this was summarized by John Rex in some works. We're trying to kill living organisms that don't want to be killed, right? Their job is to stay alive. They stay alive by developing resistance. That's a model that we're not poised to do well in. So there are economic barriers as well. They don't make financial sense. Okay, there's a really, the ability with which companies can quantitatively compare the relative value of a compound is fascinating. You know, the net present value argument, by which they can essentially assess relative assets. And antibiotics just don't stack up, is the bottom line. In general, the recent model suggests that at discovery, an IV antibiotic is actually worth a deficit, negative 50 million to a particular company, whereas the typical musculoskeletal drug will have a value of $1 billion. And so really the question is very simple. I mean, where would you put your R&D investment dollars, right? That's the problem. And so there have been issues from a regulatory perspective as well. The FDA has been in a highly difficult situation. These are really smart people working really hard to try to do the right thing, and they're getting pressure from all sides, including Congress. So they've been trying to rethink how clinical trials can get done. And initiatives, and Duke has been a partner with them in these efforts, including anti-infectives. But there have been challenges. And one of the problems relates to non-inferiority. Now, you all know this probably better than I do, but the issue of if the experimental drug is similarly effective to a comparator drug, then there are two possible interpretations of those findings. Either first, both drugs are better than placebo, or alternately, neither drug is better than placebo. Okay? In other words, in order to distinguish these possibilities, the FDA wants the comparator drugs in non-inferiority studies to have been previously shown to be superior to placebo. It's perfectly reasonable, right? Because then you've got the Pythagorean theorem, or if the comparator drug is greater than placebo, and the experimental drug is equal to the comparator drug, then it stands to reason that the experimental drug is greater than placebo. So that's perfectly reasonable. But there's one problem that's particular to anti-infectives, and that is that antibiotics arrived 2 decades before placebo-controlled trials essentially were identified and employed. And by the time these placebo-controlled trials came around, it was effectively unethical, for obvious reasons, to do them in serious life-threatening infections. I mean, you can imagine trying to enroll a patient into a trial of Staph aureus bacteremia. I know what drugs work. And telling Mr. Jones that they're going to be randomized to a trial where they have a 50% chance of getting a great drug or a 50% chance of getting normal saline would obviously, have some major problems. And so for those reasons, it's unlikely these trials will ever be done. That's one of the challenges from a trial design perspective that we're dealing with. And so this kind of led, in 2007, there were some skeptics who were even considering whether to require placebo-controlled trials for community-acquired pneumonia. Okay, this was serious discussion about it. And just to remind you, community-acquired pneumonia, that's that little thing that Osler described as captain of the men of death. So if you're going to have a randomized placebo-controlled trial of the efficacy of a drug versus placebo in the captain of the men of death, that is unlikely to make the New England Journal. And because in many reasons, this paradigm of benefit of anti-infectives has already been shown. The utility of antibiotics has already been well shown. That's the message, I guess, to say. In a whole host of different infection types. Pneumonia, 25% actual reduction in death in community and hospital. Endocarditis, essentially uniform in the mortality in the pre-antibiotic era. One of the most telling articles you're going to was of a young medical student in the 20s who described essentially his own, who developed viridans endocarditis from rheumatic heart disease, and described the manifestations of all these classical findings on himself, and ultimately died of viridans endocarditis. Gustav Mahler died of endocarditis. Brain infection, 60% mortality reduction. Skin infection, even skin infection, 10% reduction. So, problem, summary. We're running out of antibiotics. Resistance spreads. Scientific challenges to new drug discovery are plentiful. Economics unfavorable, and U.S. regulation, I think it's fair to say, have in this particular instance not made things better. Now, there are some who would say it in different ways. If you ask Brad Spellberg, he would use much more colorful language. But I think it's, it's not for lack of trying, but the bottom line is it's been a challenge. I think that's what we can agree on. And so, okay, so given that, so where does this ARLG fit in? What is it? Why do we care? Hopefully you get an introduction or a basis of why it should be something relevant, but what is it? So just to begin this thing, this was an initiative that in many ways looks like the ACTG, the AIDS Clinical Trials Group. This was an initiative that the AIDS Clinical Trials Group arose out of the dawn of the AIDS epidemic, where we were confronted at that point with a scenario not that different from what we find ourselves with today. A lot of problems, a lot of concern, a lot of interest in seeing a better way to manage these patients. And in many ways it arose from that strategy. It's changed. There's been and I think it's fair to say that this has been an incredible privilege. Wow, to be able to be part of building something, right? I mean, from nothing. We started with Heather, and we started with like designing the little thing, that thing up there. I lost on that one. I wanted something else, but I got outvoted. So everything, just starting from the whole. So that's been an incredible privilege. What's that Kennedy says? From those to whom much is given, much is expected. And boy, he had that right. So the RFA was initially released in 2012. The proposal was due in June. Basically, that 6-month block of time was grant writing. That was called grant writing. Then the original start date was supposed to be December of 2013. You'll notice that they changed that so that it went from December of 2013, they moved it up by 6 months, and they let us know the day before they moved it up. So, which made it interesting. And so our first year one was October 1st. So a lot, busy time. The mission, the goal of the ARLG is to prioritize, design, and execute clinical studies to reduce the public health threat of antibacterial resistance. That's the mission that we've been tasked with. And the first is sort of step on these kind of journeys, as you all know, having done similar things in your own respective areas of specialty, is to kind of pick the things that matter most, right? What do you care about? And so I literally took the ACTG operational structure, and I scratched out all the boring HIV stuff, and I kept the structure there, and I put interesting bacterial stuff in those little boxes. And that was how we came up with the priority. So gram negatives is number one, no question about it, for the reasons that I've articulated. Gram positives, because it's still part of, they're still a problem. And then infection control and stewardship, one means, I think, that it's increasingly apparent that one means of preserving and optimizing our remaining resources is to use them properly. And then an area that I think is poised right on the cusp is diagnostics. For the non-clinicians in the room, let me tell you about how people treat infections. It's that. It's a guess. We really don't know what the person has for probably 48 hours. You really don't know. You can guess, you can have a good idea, and you can be right. But the truth is, you don't really know. And in that instance, sometimes that time uncertain period is manageable. Sometimes you can say, well, they're not sick enough that we can wait. We can wait and see what it comes back. But you don't always have that luxury. And the folks that are desperately ill, you get points for being right and not for style. Okay, you gotta get an S somewhere in there's got to be an S. And so what is the point? The point is that there is a natural and I think reasonable tendency in current contemporary medical practice to overuse antibiotics, because at the end of the day, you as the clinician are tasked with what happens to that kid, to that person, that patient that you're taking care of, not what's happening in a global scale. And the best way to sort of uncouple that association is knowledge. Specifically, diagnostics. Knowing what we have in front of us, what the patient's infected with sooner. So diagnostics are a huge piece. And then there was a structure. Now, I can tell you I've had some experience with RO1s. This is not an RO1. UM1 was not an RO1, and not even close. This thing about DMID and IID at the top, that is not an exaggeration. That is the way the structure takes place. The Leader Operations Center is here at DCRI, and there's the Statistics and Data Management Center and the Laboratory Center, and then there were scientific committees and special emphasis panels, and then it was sort of the inner sanctum. I should also point out that I shamelessly plagiarized Danny Benjamin's PTN structure. I look at his structure and I marked out all the boring pediatric stuff and I put in interesting adult infectious disease stuff. So, okay, now I'm just going to kind of walk through executive committee. So this is sort of the decision, the place where decisions are made. This was a dual PI thing, so there were a number of political reasons for that, and it turned out it was a good idea. There's so doggone much work. There's no way on God's green earth that one person's going to get it done. I can tell you that, at least in my experience or my impression so far. Chip Chambers and I are sort of dual PIs. I'm the corresponding PI or whatever you want to call it. And we basically broke it down Chip is dealing with operational, the science piece, and I'm dealing with sort of the operations piece. Scott Evans up at Harvard was the Statistical Data Management Center core. I know there's statisticians in the room, and I'm just saying, well, I'm sorry, guys. There was a political decision. Scott, that's where the ACTG the statistics had been held for the last 20-some years, and that was an entity that was familiar with DMID. And that's the reason we did it. I did it. I'm sorry. That was my decision. Barry Kreisworth runs the laboratory center. John Bartlett is in chair of the mentoring component. Heather Cross runs everything, but she's sort of the program leader and deals with everything. And Michelle is helping Chip. And then there are two. You'll notice there are two NIAID persons that are directly involved with virtually every decision. And mostly that's a really good thing. Let's see. Oh, there we go. Okay, statistics. So Scott Evans, and then there's a variety of different persons that I'm not going to drag this out too much other than to say that there are a host of different individuals that target the specific areas of importance in terms of biostatistics. And then there is a partnership between clinical data management, which is housed here at DCRI, and the biostatistical support that is employed largely through the Harvard group. So they fall under this broader umbrella of the SDMC. Lab Center. The goal here really is to, how do you say it, to be prepared for not just for what you expect, but also for what you don't yet expect. Versatility, or I guess, is the message there. And there are a number of ways by which that occurs. There's a biomarkers group here at DCRI is involved with generating a biorepository. There are a variety of those structures. One neat idea is a thing called a virtual biorepository. As you all may or may not know, if you've created those of your own, biorepositories involve cost, which is something, generally speaking, you want to give to somebody else. If you can, but yet at the same, you may or may not ever need some or all of these samples that you're storing and paying money on for years. So if there was a way by which you could know what samples are where, whose freezers they're in, and how to gain access to them in a reasonable time frame, and yet avoid the cost of that, then everybody wins. And so there's been sort of a physical biorepository which has been developed through the biomarkers group, and then also this virtual biorepository, which is helpful because, let's say for the purposes of discussion, you wanted clinically well-characterized MRSA bloodstream isolates, and I've got a bunch of them. So you could go to this catalog and pick out the ones that made the most sense to you as an investigator and request them. And then if there's a process by which they'd be approved, taken from my lab, subbed out, and sent out. And then there's a consortium. This is the part where you're getting ready for what you don't know is going to happen. The point of this slide is most of these folks that we generated, that we've assembled, all of the folks that we've assembled are established investigators in their own right. Most have active labs as well as being doing clinical research. And so what we've tried to do was sort of list what additional resources that their labs that they would bring into expertise. For example, Cesar Arias down in Texas. His big thing is enterococci. If we're going to do a trial on enterococci, vancomycin-resistant enterococci, we're going to want to bring to bear his expertise, right? It sort of essentially, that model extends across the 4 priority areas: gram-positives, gram-negatives, diagnostics, and then stewardship. Steering committee. So that's here. So that's the committee here. So this effectively is built by the, assembled, or populated rather, by the chairs of each of the scientific subgroups. Okay, so there's scientific subcommittees. This is where we finally actually get to talk about science instead of talking about operations and all that kind of mess. This is where the really cool things are happening. And then this is where, people we're prioritizing which cool thing we want to act on. Right? So these are players, each established players in their respective fields. These are the chairs. So Robert Bonomo is arguably the most established person in gram-negative pathogenesis and resistance in the country, as evidenced by the fact that two of the competitors tried to steal him away from me in the submission, which failed. Brad Spellberg is focused on gram-negatives and trial design. Sarah Cosgrove, gram-positive. So the point is, you bring together real thought leaders in their respective areas who can help all of us weigh out which one really does carry the most weight because I may have a fair, understanding of MRSA, but my understanding about special populations or gram negatives is likely to be far less than someone like Brad or Sarah or what have you, okay? There we go. So then there was the scientific subcommittees. And the scientific subcommittees reflected those 4 priority areas. Remember the 4 priority areas are gram negatives, gram positives, diagnostics and stewardship, infection prevention. And so we essentially had mirror images that replicated those 4 areas of concern. We took the scientific subcommittees, and then part of the initial grant preparation, that 6 months of blackout period, was identifying the best people in the country in each of these 4 groups, brokering agreements and getting them on board. And that's what we've done. And so I would say if asked about what the single greatest asset of this ARLG is, there's no doubt. It's the brain trust. There are so many, there's so many smart established people in each in their area that to bring to bear on an important question, that I find that to be our greatest asset. So there were 4 committees, and then there's what you call special emphasis panels. So these are things like pediatrics and PK and special populations, which may well inform trials that involve some or more of these groups. I won't go through all the list other than to say that once you took the gram negative subcommittee, then you had a chair and there were members of it. And so each of these folks were deliberately and approached and selected. And this model is fundamentally that of the ACTG, AIDS Clinical Trials Group, which in the ID world, has been one of the most successful federally funded initiatives in our time. So, building on what we know to work. Gram positive, same structure. Diagnostics, fundamentally the same. Stewardship and infection prevention, the same. These are, so there, in some, there's something like 40-odd individuals from roughly 30 sites across the country that are involved in to varying degrees on this initiative, at the epicenter of which is a DCRI. PEDS, and PK. So mentoring, I will mention that. I think that one of the focuses of the grant, which I was encouraged to see, was an emphasis on mentoring. I was pleased with our ability to respond to that component. I feel like we have developed some tangible methods to approach that important point. There's some, now let's be real clear. Mentoring is something that a number of folks here at the DCRI has down well. And all of you folks in the room, the established PIs, have done a remarkable job, and it's been easy for me to sort of emulate what many of you all have done. And I feel like based on that in part, we were able to assemble a mentoring corps that I think made sense. So essentially, you get a number of folks who are involved in the ARLG for other reasons, and have a track record for success of it. A number of us have K-24s. A number have, and then basically provide to the trainee the ability, both sort of in-kind support, so the statistical support in terms of trial design, financial support in a number of ways. There's a thing called ESI seed grants, which is a mechanism by which the trainee can get funding of up to $50,000 direct a year for a project related to antibacterial resistance. We've already funded one and have 2 more that are under review. And then the ARLG Clinical Fellow Program, which is basically directly a chapter taken directly out of the cardiology playbook. where you get the fellow, they come, you embed them in projects, they get their masters, and you have the funding pay for that. So that the first ARLG fellow has been identified, Julia Messina, and she'll be starting in the fall of 2000, whatever this year is, 14. Oh yeah, so priorities. This is the interesting. So then the question becomes, so what? We got about 10 minutes. Research agenda priorities. From the you look over it, and one of the things we did early on was, okay, what are we going to do in MDR gram-negatives? So priority number one was the MDR gram-negatives, right? And the goal eventually was identify and design transformational clinical trial to improve outcomes of MDR gram-negative bacteria and minimize opportunities. Stewardships, very fundamentally the same thing, is try to identify what is it that what does success look like, in a word. How do we know when we found it, achieved it? How do we know when we fail to achieve it? Can we define it? And so that was the purpose of establishing priorities. And some of the projects, and then based on those priorities, from that, start targeting projects. And the projects could arise internally. We had several that were proposed as part of the actual project, and in fact, in very short order will be available for submissions from the greater scientific public by way of the ARLG website. So there's a paper that's now in press in CID, is essentially hanging up the shingle. The title is Antibacterial Resistance Leadership Group Open for Business. And in that, it identifies, the website by which that investigators can pitch scientific ideas. There's no guarantee. I have no idea what's going to happen. But my guess is there are probably some pretty good ideas out there that we simply haven't thought of. And so the goal of this additional window would be a means by which to have the scientific community provide the scientific community with a reasonable opportunity by which to engage in this initiative. This trial is, I think, the acronym is PRIMERS, and basically it's a mechanism by which the goal of this is to evaluate 4 molecular diagnostic platforms in highly resistant gram-negative bacteria. This was one we proposed at the beginning, and essentially compare the ability of these molecular platforms, all of which are in varying stages of early development or what have you, to discriminate between resistance and susceptibility in bacteria early. This has profound impacts from a clinical perspective because you know what to treat, but it also has a huge impact on clinical trials design, because a number of these compounds that are out there are a number of compounds that companies are sitting on. The problem is they don't cover everything. They typically target one organism or a handful of organisms. Let's say, for example, they target Pseudomonas, but they can't cover Acinetobacter. Well, now in the current state of technology, by the time you know it's Pseudomonas and not Acinetobacter, 3 days have gone by, and in terms of pursuing a trial from the perspective of regulatory purposes of drug approval, it's going to be difficult to attribute your outcome in that patient if you start the drug on day 4, right? The converse of that is you enroll them empirically. And the possibilities in that scenario to this investigational drug with a limited window, the problem there is that you run the risk now of giving a patient an investigational compound that doesn't work against their bacteria, and you don't know that until 3 days later. See, so that's obviously a non-starter. This is an attempt to try to overcome that, and there are basically a variety of platforms that are being tested. So either Abbott Plex ID, the Qiagen, or TACMAN, which is essentially a multiplex real-time, using testing of the 21 beta-lactamase targets across all these platforms. And they're using known CRE pathogens from New Jersey and New York, and then basically comparing them. I'm just showing you the sort of what the projects are. There are some preliminary data, and in fact, we've presented at a couple of these data at a couple of scientific meetings to date. But this is just the point of this is just to give an idea of what's been done to date. DICON, this is one of those unique resources that Duke has. It's remarkable what Dan Sexton has been able to assemble. So effectively, the acronym is Duke Infection Control Outreach Network, and it's a community of community hospitals that Dan and Dev have been able to partner with to provide infection control. And now they're expanding into stewardship and so on. So the goal here is to try is looking at stewardship and specifically asking, are there ways that we can, optimize antibiotic use in the community hospitals? Because the reality is, most of the studies that get done are done in places like Duke, and most of the care that gets done are done in hospitals like Granville Medical Center. The community hospital, that's where the majority of Americans continue to receive their care. So there's a disconnect, and can you address that in the setting where patients actually get treated? I'm not sure why I have that slide there. Oh, I remember, mentoring committee, we talked about that. And I think, and we mentioned the points, seed grant, this is the $50,000 a year, ARLG fellowship, and mentoring, particularly with regards to K scholars. Projects that are ongoing with existing ARLG projects and trainees that are involved in them, and the website. So I think that's it. Yeah, there's an application process by which to avail yourselves of these resources, and I believe that. Oh, that's the end of it. I know what this is. This is why there were 100 slides. I think I pasted it in. Oh, this is some cool data. This is the primers data. I won't tell you about it. It's really cool. This little box right here in particular. No, this is kind of the complexity that you're dealing with and why you need to be able to superimpose it, some simplicity. So, in summary, then, ARLG 1, it's up and running. Thanks in large part to many of the people that are in the room here today. This is not sort of a false modesty thing. This is just the darn truth. There is absolutely no way that this thing could have been assembled without the incredible work of a number of just dozens of people, most of whom are here at the DCRI. I'm incredibly grateful to them and for the opportunity to lead this. It's a new initiative for critical need, and I hope it will be a good investment. I believe it will be, and I intend to make sure that it will. And then I've got to put this at the end. That's the acknowledgement, limitations, opinions, etc. And then here, if I haven't mentioned, this is how to receive your CMA credit. So thank you very much for your time.
Great. We have a few minutes for questions. Anybody?
Hey, Vance, that was phenomenal. If we didn't know there was a problem beforehand, we know there's a problem now. So we'll all feel much better as we wash our hands after the meal here. I guess the question I'd have for you, this is great, you caught us up to where you are. You didn't talk a great deal about where you're going.
Yeah.
And in part, if you could also talk a little bit about how you might imagine that world being different as we enter an era where hospitals are linked together with various EHR systems and sort of where we're going outside of your effort, but more outside of the traditional trials into the newer novel worlds.
Sure. So question one, where are we going? And question two, how are we going to get there, particularly with regards to EHR? From the perspective of where we're going, I don't think I'd ever be put in a position where I'd say that, whatever it is, $100 million is not a lot of money. It's a staggering amount of money. But even with those sums of money, there are limitations to what you're going to be able to get done. More so in this instance, I would say the rate limiting resource is probably time more than money. Given that, I think we got to focus and prioritize accordingly. First one's going to be gram-negative. There's going to be a transformational trial There's a compound that we have identified, have a sponsor with. There's a phase 1 that's establishing PKs. I can't actually say the compound, but you're right, I didn't mention that. That was by design, not by default. But a safe, targeted agent that's not currently available here in the United States, that is, however, available as an IV agent in Europe. The goal would be to change that, and specifically to make this compound available as an IV preparation in the United States. So that's project 1. And there's a face-to-face with sponsor and DMID in a couple of weeks' time. Ron Roddy is a project lead on that. I think the second project, I think if we can achieve 2 transformational trials, we've done a good day's work for a good day's pay. I don't think, I suspect that's really, at the end of the day, what's going to happen, where things are going to be. The second trial, what I would like to do, where I would like to see it go, is a definitive trial on persistent MRSA bacteremia. I can talk about this one because there's, I can. And what I'd like to see, the trial I would love to see done would be a comparative trial of ceftaroline, vancomycin, and daptomycin for the treatment of persistent MRSA bacteremia, non-regulatory. There's some challenges to that, a number of them, of which I am intimately familiar, having right now also running a bacteremia trial, not the least of, probably the foremost of which is enrollment. So that's right now the second target. It may not be you don't get everything that you want in life, right? So those are our 2 targets. With regards to how we're going to get there, the EHR, that's a great question. It actually would lead well into the structure that I didn't go into, but by which DMID in general and Tony Fauci in particular would, I think, envision this to take place, and that is through existing mechanisms, things called clinical trials units. These were structures that in the HIV era were used to conduct clinical trials. The short answer is they would envision those same structures largely populating clinical trials in anti-infectives. Now, that sounds good. There are some practical differences between a healthy, educated, empowered outpatient with HIV and a ventilated, critically ill patient on 2 pressors in the intensive care unit. That will, by necessity, complexify, if that's a word, now it's a good word, enrollment. But I think that EHR would be very helpful in knowing for things that are currently stored electronically in all these sites. Like, for example, what's the prevalence of CREs in all these CTU sites? We know they're not the same. We don't know what they are. And boy, it sure would help if we were trying to design a trial that was focusing on CRE. So that would be one place. I think that in anti-infectives in general, that's an area where EHR really would help. I'll stop there.
One's a softball. I'll give you that one first.
Thank you.
And then I've got a little hard one for you.
You're just too good to me.
I am. I'm nice that way. So the softball is, when about 2 years ago, we went over what, the mistakes that I had made with the PEDS Trials Network, and here's 4 or 5 things I would do the same, and here's 4 or 5 things I would do differently. From an operational perspective, what can you tell us about the things that you would do differently? And maybe 1 or 2 things you'd do again.
Well, recognize, we're 8 months into this. One thing I suspect I would do differently, knowing the very little bit I did, would be, how do I say this politically correctly? I would like to ensure that more of the decision making and in general and specifically time sinks in particular are controlled at the DCRI rather than other places. like Bethesda, for example. That would probably be, and to the extent that I could design a transformational trial where all the decision making and time and all the time sponges are retained in an environment where change can occur, or, well, I'll stop there. But that would be it. You know, the reality is they've got a tough job, those guys, right? It's hard. And they've got a lot of stuff. And they got people looking at them, scrutinizing everything they do. Change is generally bad. And, you know, it's tough, right? But at the same time, we get tasked with, we got to get this stuff done, which means there's going to have to be some change somewhere. Figuring out a way, probably being more proactive in finding ways whereby we could partner with our NIH colleagues to optimize the environment for change.
Had the grant for 8 months now, congratulations. What date are you going to enroll your first patient in your first trial to receive a therapeutic? Because the former director asked me that question the day after actually I received the Pediatric Trials Network. So what date are you going to commit to there?
Yeah.
Transformational.
But see, it's so tough, Danny. You don't understand. It's tough, man. You know, you got to feel my pain. It's hard. So the short answer is, realistically, and in terms of interventional, high-resource clinical trials with the phase 2 compound that we are most interested in, probably year 3. Probably. Maybe year 2. Really, I'm just telling you realistically. It may be year 2. The phase 1 data is being done now. So if that counts, then maybe that counts. If you want to count the PK data, I could give you the answer. That's happening right now and maybe in the next 6 months. But realistically, I don't really count the PK phase 1 just because that's not what, I mean, at the end of the day, we were tasked a little bit differently than kind of like Peds Trials Network. And so once we get the, when I count sort of success when the first patient gets enrolled in trial, and I can see there are going to be some hurdles to that. So realistically, probably year 3. I don't like that, but that's kind of how long it's taken water to boil. I'm not sure what I can do to fix that thing right there. I mean, I'm happy that people can hammer me about it, but that's life. There going to be some other ones. There going to be some there going to be some enrollments and some institutional trials that are happening. DICON things happening. The lab stuff is happening. There's QI stuff that's happening. I didn't go into all these projects that are happening. There's papers that are enrolled. We've got cohort studies that are enrolled, but that's sort of secondary in a way. The goal is to get that compound available to the American people by the life of grant, and that's year 3.
Time for one more question.
Thanks for that great presentation. Well, one of the things that you keep on alluding to is just, I guess, the interface with industry.
Yeah.
And what role did that play in, as you assembled the group together for the grant submission, and what's the formal interface that you have now that you've got the group up and running? And then sort of corollary to that, how does that interface with what the industry is already doing in terms of trying to pull knowledge and resources together around also tackling these issues?
So that's a complicated question. But in brief, pre-grant, it was the relationship was largely informal and based on existing relationships with people that I knew from previous clinical trials. As I suspect many of you all are reasonably familiar. You know these people, they trust you, they trust your word and your work, and you say, this is what we're kind of interested in doing, and they say, okay, good, that sounds cool, it aligns with us, or no, that's really not where we're going. And post-award, it's been variable. There have been several number of projects that have been pitched related to try to get funding for projects. They've generally not fared well for a variety of different reasons, not that were solely hinged on science rather than other issues. I think that the partnership concept is ultimately highly appealing in theory. There are some timelines. One of the challenges is inevitably going to be timelines. And that's one, the disconnect that I can see there between industry's timelines and NIH timelines. That's a tough nut to crack. I think, and I don't think it's impossible, but I think you've got to have there's a sort of convergence of circumstances that'll arise for it to make sense from a business model to essentially downshift to first gear and let NIH, in return for government shouldering a portion of the development cost. That's a trade-off that has to make sense for that particular sponsor. And I can go into specifics afterwards, but in general, that's where I would sort of, looking back over the last 8 months, that's kind of the theme that's recurred.
Great. Thank you very much, Vance, and all the best with this very
Thank you.
important work.
Thank you. All right. Yeah, thanks. I appreciate it.